very excited for this Global Health Technologies panel for this meeting the needs. And I think this is a very important subject for this particular conference, because meeting needs, to me, has many underlying implications. We are talking about meeting something, and how are those needs defined? And so I think throughout this presentation, we're going to hear from some wonderful panelists on some of their work at the intersections of medicine and engineering, and where technologies can be applied in more resource-limited settings, and more importantly, the processes that one goes through in order to set up things that are locally owned, locally driven, and what are some of the challenges to doing things in a capacity-building way. That's what I'm hoping we'll get through in the next hour and a half or so. So I'm very happy to start by introducing Dr. Marian McCord, who is in the departments of Textile Engineering, Chemistry, and Science at NC State University, North Carolina State. She actually is doing a lot of work internationally with the use of textiles, but also how these technologies can be leveraged to help the world's poorest with the largest burden of disease and most grave problems. So I'm going to go ahead and hand it over to Dr. McCord, and I'm going to pass you a microphone that may or may not reach.
About if I come over to the side.
This is how we're going to
Okie dokie.
Oh, you're kidding me.
Well, that's okay. I can probably talk without slides.
Your slides are here.
Oh, great. Okay.
It's
Awesome.
on.
Thank you, Matt, for the introduction, and I'm sorry to stand in front of you. Yes, okay. Thanks, everybody, for coming today. I'm just going to share a little bit with you about who I am, how I came to where I am, and what I'm trying to do, and just one of the efforts that we're working on at NC State right now in our global health initiatives. As Matt said, my background is I have two degrees, an undergraduate and a master's in biomedical engineering, and a Ph.D. in textiles and polymer science. So, you know, when you tell people you work at in textiles as health interventions, they kind of give you a funny look. But I work both on the preventative side, disease prevention side, which would be things like non-toxic insecticidal bed nets. I also work on antimicrobial and antiviral fabrics, chem bio type protective clothing, and then on the treatment side, I work on high-tech bandages that are affordable, and hemostatic bandages as well. But there are a lot of intersections between textiles and medical devices. So I've been a faculty member at NC State in textile engineering, chemistry, and science for 18 years, and in 2002 I was one of the founding members of the Department of Biomedical Engineering, which is now a joint department with UNC Chapel Hill. About 3 years ago, I was asked to step in a half-time role as the Director of Global Health Initiatives for the university. And you have to understand, we're a land-grant university without a medical school. So part of my journey in this position has been defining what the role of a land-grant university is, without a medical school, is in global health. And really, our university's strengths are in engineering, infrastructure, agriculture, food security, veterinary medicine, zoonotic disease. These are our major strengths. So in thinking about what I wanted to do in global health, I had to use this frame of reference, and also keep in mind our mission, which is has been traditionally very North Carolina focused, and refocusing that mission so that North Carolina is now part of the world. Okay, so I'm going to talk to you about this effort, the Global Health Pulse, this partnership in sustainable undergraduate learning in sustainable engineering. So the motivation for what we're trying to do is, of course, the unmet need in global health around the world. Our university recently went through a strategic planning process, and we have as one of our goals to become more international, more global, and also to address the grand challenges of society. So in thinking about programs, I always think, what is our university's mission? And then I also believe that we have a need in the industry to train a workforce that is prepared to address this enormous unmet need, this enormous emerging market. So next slide. So the opportunity really here, I think, is to create a partnership, a sustainable partnership, because sustaining is very important, between NC State, nonprofits, NGOs, industry, and government. That's going to result in a win for all. So how do we do that? We can identify and target emerging markets for medical device and product development by engaging existing partners and taking advantage of well-established networks, networks that our partners have in country that will allow us to really access potential users. Training the workforce that is going to effectively engage with local stakeholders. And this is not something that they're just going to figure out on their own. It's going to take some training so that our students get the skills to co-develop solutions with users in communities, not to design solutions for them, but to give them the opportunity to co-develop those solutions and to build capacity for innovation and commercialization, both within our local community and abroad in medical device technologies, global health type technologies. So looking at the resources that we have at NC State 6,000 undergraduate engineering students. It's a small town on its own. 18 undergraduate engineering majors, over 40 global health student clubs. We have leadership programs. Last year we had students on 20 separate alternative service break trips. These are trips that the students take during spring break time. They go to low resource settings. They usually do some kind of service. And we also have local partnerships. We have in the Triangle, the Triangle Global Health Consortium, which is a consortium between Duke, UNC, NC State, several NGOs and nonprofits, RTI, FHI, and it's a very effective network for interfacing with other people in the global health sphere. And then we have international partners, and we have over 200 international partnerships globally. So taking advantage of all those resources, next slide. We have proposed and we are piloting this project, Global Health Pulse, Partnership for Undergraduate Learning in Sustainable Engineering. And the goal is that because we have these 18 engineering majors and all of them have a capstone project, which is either 1 or 2 semesters long, we're going to focus on a few of them to begin with, biomedical engineering and textile engineering. I wonder why. And the goal is to send them somewhere where we have an established partnership and where there's a network that they can tap into, somewhere where we have a relationship that's a sustained and sustainable relationship, either via our partners or through NC State itself, to get them into hospitals, clinics, and communities where they can actually do a needs assessment rather than handing them a project. So they go to the communities, they talk to people, they learn what are the challenges here, and then they hopefully also have a network with industry in the country. They're able to examine the supply chain, they're able to look at the innovation ecosystem in that area, infrastructure, and form teams, involve local stakeholders, local industry, et cetera, and then come back to the U.S. and try to work remotely over time to co-develop solutions and then travel back to the location again in the next semester and look at how well they're doing in meeting the needs, bringing prototypes, et cetera, and evaluating them. And on the way, we hope that they'll develop a proposal after they go to the first trip, and then when they finish their project, we hope that they'll enter an engineering design competition. So the challenge is, this is a great idea, but as you might expect, the challenge is sustainability, and the biggest challenge in sustainability is finding a sustainable funding source, because it costs several $1,000s for the students to travel. And if we really want to engage students on a large scale, and that's something that I want to do, that's going to cost quite a bit of money. As I said, 6,000 undergraduate engineers. Convincing students that they need to leave the country, that this is something that they need to do. And that's working with industry to tell them as well, these are the types of students that we want to hire. So this is a bit of a sales pitch to them. Creating a true win-win situation where the communities actually get something. They're not just a place for our students to go and learn. There's something that's actually commercializable, that's developed. There's capacity building that happens, and that our industrial partners and our NGO and nonprofit partners also benefit from this process. And continuity. We don't want to walk into some place, spend 1 year there, and then walk out. So these are the challenges that we're facing, and I look forward to the discussion and any ideas that you have. Thank you.
I've been involved with EWH off and on since 2009. I actually was a participant in the Summer Institute in 2009. I went to Tanzania for 2 months, and I'll give you guys some more details about that program in my presentation. I graduated, before I went on the Summer Institute, I graduated with a BS in bioengineering from Clemson University. And after the Summer Institute, I did a little more traveling. I went to Vietnam and taught some seminars there at a university that I was connected to with some family friends. And then I went back to Clemson, started a Ph.D., but decided it wasn't the right track for me. And fortunately, EWH was looking for someone to manage this program. So I jumped on the opportunity and have been very happy since. I've been working at EWH for about the past year. November 1st was my start date, so I guess a year and a few weeks now. And EWH, we're a small not-for-profit in Durham, North Carolina, and we focus on the needs of developing world hospitals, mostly focusing on equipment repair and some on the design and innovation side. Go ahead and put the slide for me there. So our real goal is to become the benchmark in providing this education in this area. We're really the only organization that's really been focusing on this, and we're in fact the largest organization, mostly through our BMET program, which is sponsored by the General Electric Foundation. And at the bottom there, what we're trying to do here, it's a little bit cut off, is we're trying to empower caregivers, engineers, technicians, and students to come up with solutions for this area of resource-poor hospitals. So a little bit of background or the local challenges that we try and deal with. About 80% of the world's population lives on less than $10 a day. I think $1 a day has sort of been a common poverty line. They've just started using this a lot in literature. So I think it's really indicative of the problems that we're trying to tackle right now. In many sub-Saharan African countries, even spending $15 a year per person on healthcare is out of reach for most people. As you guys probably know, most of the medical equipment today is designed for economies that spend up to or over $2,000 per person per year on healthcare. So this has led to a massive gap in technology availability for most of the population of the world. So what we often deal with is donated equipment, and this is what we come across is something similar to what you see in this picture, which is just closets full of broken equipment, or sometimes even operational equipment that just hasn't been installed and there's no user training, or they're missing other aspects of infrastructure or supplies they need to operate the equipment. So what some research has shown lately is that in the developing world, over 50% of the pieces of equipment are out of service. When they arrive, about 40% of donated pieces of equipment are out of service. So this is a range of different reasons, from it just not working, it's missing consumables, it's missing chemicals or other supplies that it needs. And we've seen in sub-Saharan Africa, this number gets up to 70%. And after 5 years, only about 2.5% of the equipment is actually still being used. So here's the stats in a graphical format so you guys can see. And like I said, after 5 years, only about 2.5% of the equipment is actually still being used. So a huge issue. We're tackling this in a number of different ways. We have the Summer Institute, which is mostly geared towards undergraduate students, but it's available to any engineers we've had. We had a guy in his early 50s this past summer go through the program, so that was great. We have the BMET training program. This is where we train local technicians on how to repair equipment. We also have our domestic programs, which are mostly geared towards students in Europe and the United States. And it's chapters and a few other programs we have listed here. We have a KITS program, we have a design competition, and we're trying to get more involved with STEM, which is science, technology, engineering, and math. This is a K through 12 push. It's very strong in the US right now just to try and get more students interested in these fields. So the Summer Institute, this is really how EWH got started. It was started by Dr. Bob Malkin and Dr. Muhammad Kiani. I think they were at a university in Tennessee when they started it. Dr. Malkin's at Duke University now. But it started with him taking groups of 5 or 6 engineering students around the hospitals in these countries and realizing there's just a lot of work that could be done with just a little bit of engineering know-how. So slowly over the years it's grown into a more formal program. During the first month, students get intensive language and technical training, and during the second month, they work independently in groups of 2 or 3 in hospitals to make repairs, do some innovation, and just basically help the hospital out however they can. In the past, it's been in Central America. Nicaragua is where we're focusing now. Tanzania, we've been running that program for about 10 years. And we're really excited. We're starting a new program in Rwanda with Dr. Maitland here and Texas A&M, so that will be starting this coming summer. So since 2004, we've had over 400 participants. We have about 24 hospital partners right now. Expanding to Rwanda, that will be closer to 35 or 40. We've repaired over 4,800 pieces of equipment. We have about a 73 to 80% success rate. In other words, if a student starts to work on a piece of equipment, they have over a 70% chance of actually making a successful repair. And using a nominal value of about $2,000 per repair, we've repaired close to $9 million worth of equipment. We're actually working with some students at the London School of Economics right now to hopefully get a more accurate picture of that, since there hasn't been really a lot of research done in this area in terms of, an X-ray machine in the middle of the city is sort of arguably less valuable than an X-ray machine that's in the middle of a rural area where it's the only X-ray machine for thousands of miles. So we're trying to take these types of values into account. And another great thing, and really the valuable thing about the Summer Institute, is the students sit down with the doctors and nurses and do needs finding interviews. So we have a very structured interview process that the students go through. And from that, they feed into a list we have called the Projects That Matter list. And basically, this is a list available to anyone online that has all these concepts listed out, including some background research that's been done on them. So hopefully design groups at other universities or independent groups can sort of take on these challenges. So our biggest program is the BMET program, and this is where we train local technicians. So we go into our partner countries, we go to the hospitals, we find whatever technician they have at the time. Usually at best it's a plumber or an electrician that's had very minimal training. We bring them into our program and bring them up to speed on medical equipment. The first countries it was running in were Rwanda and Honduras, and we're expanding to Ghana and and Cambodia in the future years. The BMET program is a very unique approach called the BTA skills approach. This was developed by Dr. Malkin as well. And basically the way it was developed is he went through a list of about 300 different work orders and said, what is the most basic technical skill that's needed to make this repair? Whether it's gluing something together, turning a wrench, soldering a piece of wire. From that, he developed a list of, I think, about 100 fundamental skills. And what we do with our students is we give them training on these 100 basic skills, and we give them some theoretical training too on just the basic operation of medical equipment, physiology, some electrical engineering concepts. And what we hope to do with this is basically create technicians with a very creative approach to making repairs. So hopefully this knowledge is much more applicable to many different pieces of equipment rather than training a technician on a GE model 300X X-ray machine, for example. And something else that came out of this research that was really interesting was that over 60% of the repairs could be made for under $50. And this is using local supplies. So going down to the hardware store, going down to the plumbing store, and using that creativity to make the repair. And this is a really critical fact because, well, there's a group in Zanzibar that I worked with, and they were able to take this to the Ministry of Health there and say, all right now, the technicians to make a repair, they have to fill out 4 or 5 forms, they have to wait a month or so and hope to get the funding, and then maybe the part will get shipped to them. With this fact, they're able to go down there. They start a petty cash fund of about $1,000 or $2,000, so the technicians can just go apply for a small amount of funding and go out and make the repair as quickly as possible. We have university chapters. We have about 40 chapters worldwide. They're really the baseline for us creating awareness and getting students involved in these types of problems and our projects. Go ahead. which is the next thing I'll talk about, is our projects that matter list. So this list of projects mostly came out of the Summer Institute and the needs finding interviews that the students do with the doctors and nurses. They come from a couple of other sources. You can sort of see a list here. If you're interested in actually having the entire list to look at, go to ewh.org/PTM and it will download the PDF for you. Yeah, go ahead right now, we're short on time. We also have a kits program. Usually these kits come out of our Projects That Matter designs or other design groups from our chapters. What these are is these are little, it's a kit. So right now we have an electrosurgery unit tester, and it comes in a bunch of different parts. The student groups get together and they build them and then they send them back to us, which are then distributed through our BMET and Summer Institute network. This is just really a great way for these chapters to go ahead and get started, get people like minds together and start discussing, some of the issues that EWH deals with. So I sort of added these slides at the end, to sort of talk about some of the overall observations that EWH and I have seen. So some of the biggest challenges are cost and access to parts and supplies. I think that's pretty standard. The example I like to give is there was a OR light that needed new bulbs, and they would cost about $25 per bulb in the US. Once you got this bulb into Tanzania, it was about $75 per bulb. So even more expensive once you add in the tariffs and the shipping and all the logistics that needs to be done. Of course, consumables is very similar to that. And donations is really what we're trying to tackle at EWH. So we've seen just tons of problems with these donated pieces of equipment. So some of our chapters actually work with organizations that make donations to try to improve the success rate of the donations. And the other really big issue with donations is it leads to a lack of equipment standardization and parts interchangeability. Rwanda has done a really good job of starting to tackle this problem with some policies that they've instituted with our influence. So when you go into a hospital in Rwanda, all of the CD4 counters are the exact same model and brand. A lot of the patient monitors are the exact same model and brand, so they can hopefully, not even interchange parts within one hospital, but between hospitals. And sort of similar on what that last slide was about is I think the real issue that we're trying to discuss here and that EWH is trying to tackle is how do we transition from donations to an appropriate technology market. So we're trying to convince these hospitals and these healthcare systems to move away from something that's given to them for free to something that they actually need to pay for now. And we have to, figure out a way to show them what the advantages of that are and how the donations are actually hurting them in a lot of ways.
I'm actually representing here the International Federation of Medical and Biological Engineering. I'm a member of the Administrative Council of IFMBE, and I'm also chairman of the IFMBE Working Group on Developing Countries. And I'll start by just giving a small presentation on what IFMBE is. The International Federation of Biomedical Engineering is actually an NGO for the World Health Organization, and its mission is to encourage, support, represent, and unify the medical and biological engineering community worldwide. And the whole idea is to promote health and quality of life through the advancement of research, development, application of management and technology. And it is technology applied to health, which is basically the idea of biomedical engineering as worldwide endeavor. Our goals is mainly to advance collaboration between national, international, transnational societies and organizations, industry, governments, and non-governmental organizations that are engaged in healthcare and biomedical research. And we're also involved in recommending policies and providing guidelines in appropriate professional education and ethical areas. Now, the IFMB is actually composed, being a federation, is composed of biomedical engineering societies throughout the world. You can see on this map, there's very well distributed, but Africa, there's a big hole. And overall in Asia, there's quite a big empty area as well. And Russia is one of the big countries missing. But in Africa, there's only Nigeria and South Africa. Apart from the national societies, we also have transnational societies, and actually IEEE EMBS is a member of the International Federation of Biomedical Engineering, which has a very large number of members, as you know. Within the International Federation of Biomedical Engineering, we have several working groups. One of our working groups is the Working Group on Developing Countries, which is something that I'm very, very keen on because I'm the chairman of this group. And the goals of this group is to promote biomedical engineering in the developing countries, promoting and helping the local societies, to support the development and deployment of medical devices for use in resource-poor countries, and also to serve as a gathering point of biomedical engineering projects in the developing countries. Because we have a good connection, very strong connection with the World Health Organization, some of our AC members are actually in close contact, in collaboration with the working groups within the World Health Organization. We actually are in close contact with that organization, which is where we can try and give a good incentive to the application of good technology throughout the world. Personally, just to tell you what is the reason I'm here and why I'm very interested in this, is as a member of the Administrative Council of IFMB and chairman of the IFMB Working Group on Developing Countries, I'm very interested in the technology, health technology in resource-poor countries. Personal history, I was born in Mozambique, in Maputo, where I finished my high school. And after being trained in England, where I did my university training and research, and after spending 8 months traveling around the world, where I actually came across all the reality from many developing countries, I became associate professor of biomedical engineering in Lisbon, where I'm the president of Biomedical Engineering Society in Portugal, and became very, very involved afterwards with the International Federation of Biomedical Engineering. Personally, I'm actually involved in a training project in medical imaging at the Central Hospital of Maputo in Mozambique, where I will go within a week. In less than a week, I'll be there in Maputo. So being from Mozambique, still having family in Mozambique, having very close contacts in Mozambique and going there regularly, I know the reality of Africa, in particular Mozambique. And I'm very, very keen on doing all that I can to help the Africa in general, in particular, and the developing countries overall. If you want to get some more information on IFMB, there's the site for IFMB, ifmb.org, where you get some extra information. And if you want any information from me, there's my personal email, which is one of university email and another more personal email. And I'll be really happy to get along with all of you and discuss any more ideas and get any questions that you want. Thank you.
Thank you, Mario. All right. We're going to try and make it so you can actually see things now. Okay. So I'm actually going to invite up Mr. Ryan Littman-Quinn to go ahead and give us our next presentation. Ryan works with the Botswana-UPenn partnership. This was my previous employer in a previous life, working with the Penn program on their mobile technologies programs, their medical informatics program, and I've asked him here because I think he'll bring an interesting perspective about some of the systems approaches to implementing these projects on the ground in a collaborative way. So, Ryan.
Thanks, Matt. So as Matt said, my name is Ryan Littman-Quinn. I'm the Director of Mobile Health Informatics for the University of Pennsylvania in their NGO, which is called the Botswana-UPenn Partnership. And in this role, I've been living and working in sub-Saharan Africa for the past 3 years. I've been focusing most of these projects in Botswana, but I also have consulting work in South Africa, Kenya, Uganda, Guatemala, and the United States. And today I'm going to bring more of a programmatic perspective on implementing new technologies in resource-limited settings, and specifically Botswana. So just a quick look at what I'm going to talk about in the next 5 to 10 minutes. We'll ask this very important question: what is truly useful tech for global health? I'll give you some background on our program, I'll go through our projects, talk about our keys to sustainability, and the challenges we've had. So this question, I think Ben did a really great job outlining what a big issue this is in global health. It also had very interesting timing for me. So I was in Guatemala in August, and I was in a rural hospitalito in Guatemala, and I was meeting with their administrators about some mHealth projects. And when I was talking to them, I mentioned the word telemedicine, because that describes a lot of the projects we do. And one of the administrators perked up and said, "Oh, you work in telemedicine? Come with me." And she brought me down to her basement and showed me this machine. I took these photos with my cell phone, and they said this was a machine that was donated to them over a year ago, and it hasn't worked in 8 months. And she was hoping I could fix it. Unfortunately, I don't have the technical engineering expertise to do that. But this is a very common issue in global health and in development. And it's so common that in South Africa, I have some colleagues, they call them museum exhibits. Like Ben said, in Africa, over 70% of these donations end up not being used, and they just become standing in facilities and museum exhibits of sorts. So, next slide. So in our experience, and what tends to be a big trend in global health and development these days is using mobile technology in development. It's proven to be a very useful platform for health. Go ahead. Quick background on Botswana. Botswana's a landlocked country about the size of Texas in sub-Saharan Africa. Has very challenging landline IT infrastructure. The internet's unreliable, spotty. The vast majority of computers have viruses, etc. Ranks second in HIV prevalence and fourth in TB prevalence in the world. So their public health care system is heavily burdened and stressed, and they have a severe shortage of healthcare workers. So part of what we do at the Botswana-UPenn partnership is we're an NGO to try to address these issues. It's an NGO, it's technically a partnership between the Ministry of Health of Botswana, the University of Botswana, and the University of Pennsylvania. And our program is a health informatics capacity building program, and we work with local academic groups on incorporating health informatics into their curriculums to try to build more of a health IT and health informatics workforce in Botswana. We also conduct workshops and help host an annual conference on health informatics every year to try to get everybody together, sharing ideas. And we also spearhead mHealth initiatives with our various partners. And the projects I'm going to share with you today are our telemedicine projects and mLearning projects, although we are doing several more. So a quick look at our telemedicine projects. These are all store and forward telemedicine. So the way these work, we have implemented in 4 different specialties: oral medicine, cervical cancer screening, dermatology, and radiology. And these are all specialties that are heavily influenced on visual inspection. So what we do is we train people around the country to collect information on mobile phones. They take pictures of the mobile phones on complicated cases. That information is uploaded to the internet, where local specialists in the capital city or at University of Pennsylvania will review case data, send back a diagnosis and treatment. And you can see we've had over 600 cases, and these are ongoing projects at the moment. Just some photos from the projects. These are some of the clinical photos from the cell phones and some of the dental officers using the technology. And just a few more photos. You can see we've used different models of phones over the past 3 years. And now I'll talk a little bit about our mLearning project with the University of Botswana. So the University of Botswana founded their first school of medicine in 2009. And part of their goals is to have all the students and residents have experience in the rural areas of Botswana and do clinical rotations outside the capital city. So we've partnered with them to try to support their students when they're outside of the capital city. So we give them smartphones, and now we're using 7-inch tablets that we load up with health information apps, drug reference apps, local treatment guidelines, lots of library resources. We work very closely with the University of Botswana Library. And we've also come up with customized, innovative SIM card packages. So they try to incentivize the users to use their data on their SIM card for the health apps as opposed to Facebook and other non-health apps. Just a quick look at the growth of this project over the years. In 2010, we did a little feasibility study just with 7 students in the capital city and smartphones. And this year, we're setting up 150 7-inch Android tablets in the capital city, but also 3 villages where the students are rotating. These are just some photos from early on with the smartphones. And now I'll talk a little bit about what we've recognized as the key pillars of sustainability for our projects, and that's local ownership and drive with our local partners, the IT support model behind these projects from when they're pilots compared to when we're scaling them up, and then public-private partnerships. Excuse me. So these are just some photos. Like I said, we're scaling up this mLearning project to 150 devices, And what we did in the past is we programmed cell phones in UPenn and just brought them over. But this time we purchased all the devices through local distributors in Botswana and South Africa, and we set up all the devices at the University of Botswana library. So we had a full-day workshop training people how to load up all the resources on these devices so the university can do this on their own in the future. We have a similar model. This is from our telemedicine project and the oral medicine project, where the trainings, the training materials, and all the logistics are actually handled by the Ministry of Health and our colleagues there, and people we call specialty managers. So for each project, there's a specialty manager who spearheads these things. So it's not the external partner who's implementing and training these people, but their peers and colleagues at the ministry. This is a poster idea from the oral medicine project. They wanted to sensitize their patients to the projects. So they were hanging these posters in all the clinics where the telemedicine projects are operating. And this is just another initiative, great initiative from the oral medicine team. They wanted to better sensitize their colleagues, their healthcare workers in the different districts where we've implemented. So they run day-long workshops where it's a mix of sensitizing them and having them try the telemedicine systems, but also just teaching them about oral health. So it's a great way of kind of integrating, introducing new technology with existing practices in Botswana. So now I'll quickly touch upon the IT support model. So for our pilots and studies, we were using proprietary software supported outside of the country. It was actually a group out of MIT called Click Diagnostics initially. But what we found is that for long-term implementations for these scale-ups, and is, you know, in the same spirit as our capacity building, it's better to use open source technology supported by local IT groups, and that also adds to the local ownership of things. We try to do that as much as we can with our projects. Another thing in terms of public-private partnerships, none of these things will be sustainable unless there's public and private partners involved and everybody's winning and profiting from it. So we've worked very closely facilitating these partnerships, negotiating special rates with our private partners and public partners to make sure everybody's winning. And for all the projects we're scaling up, we're very happy that we've finalized MOUs for 3 years for each of the projects with all the different parties. Now a quick look at challenges. I'm not going to go through all of these, but basically we're kind of strangely proud of the fact I think we've had every single challenge that one can have with implementing mobile technology in a resource-limited setting, and we're actually publishing a paper specifically on these challenges and the short-term and long-term solutions we found for these different challenges that I'd be happy to share with anybody after this. Quick look at our plans this year and beyond. Basically, we're scaling up all these projects with the Ministry of Health and with the University of Botswana. We're bringing in teams from the Wharton Business School at University of Pennsylvania, but also they're collaborating with the University of Botswana Business School on different research on these projects, a very important part of sustainability. And also, we're very interested in exploring biosensor accessories for these devices. So we've implemented what's going to be around 200 Android devices. We're very interested in trying out accessories such as EKG devices and ultrasounds that can connect to these mobile devices and use them as a platform. So if anybody has any interest in that, please reach out to me afterwards. And so that's it. Thank you very much. And if you scan this QR code, you can get my contact information. So thanks again.
Thank you, Ryan. Our last speaker, last but not least, is Dr. Kristen Maitland. And actually, I think talking about optical sensing is a perfect launch point for Dr. Maitland to talk a little bit about what work she's working on at A&M. And I'm going to just let you go ahead.
Thank you. So I'm Kristen Maitland. I'm an assistant professor at Texas A&M University. So my research is in optical imaging and sensing, and I apply it to various applications. One is cancer, and one is TB detection, and that's really for facilitating vaccine and therapeutic evaluation. But actually what I really want to talk to you about is some of our educational programs that we're doing at Texas A&M. And so it was great hearing about Marian's experience at NC State, and you heard quite a bit about Engineering World Health's activities from Ben. So ours is actually very similar to NC State, and we work very closely with Engineering World Health. But instead of coming from kind of the top down, seeing from administration that we need activities with the students to be exposed to global health. We kind of started from our student chapter of Engineering World Health, and within our department, where we have a number of students that are very engaged in these programs. We have our Engineering World Health student chapter sponsor senior design teams within our department. So we've had about, I think, 7 different projects over the last 3 years where graduate students in our department and faculty members mentor seniors in a year-long senior design project. Some of them have been very successful. One of the problems we saw with how that was working is that the students working on the designs had no context for their design projects. And so they really didn't get it that the power would go out frequently, or that they might not have power, or that the lights wouldn't be on all the time. And so it was kind of a disconnect that we saw that we are trying to address. And so, and one thing I'll say is that the students love these projects. They love the idea of being able to help somebody somewhere else in the world. And so it's a great motivator for them in their education. They see why they're learning their calculus, and they understand why they have to go through these electrical engineering classes, and so that it really gives them a reason to be learning this material. They're applying it as they go through their program, and so what we've started is a new summer institute with Engineering World Health, and we've partnered with them, and we really want to leverage their experience and their network and their kind of established relationships. So we are doing this program in Rwanda. And I think Rwanda is a special case where they have a very good infrastructure, and they've really, over the last decade probably, they've really invested a lot in their health system. And so one thing that I think will be different with our summer institute, and we've really kind of designed it this way in comparison to the other summer institutes in Tanzania and in Nicaragua, thank you, is that because of the relative strength of their program in Rwanda, and also the equipment technicians that have been trained by Engineering World Health, we think that the repairs that the students will be doing will be at a higher level, and maybe there might be bigger challenges but fewer of them, and so they may not be changing light bulbs, but instead they might be working on big sterilizers. And with that, I think that they will have a little bit more time to focus on the needs assessment and actually coming up with designs while they're there. And so you heard a little bit about the summer institutes. The first month is a month of training where they learn language and technical training. And so in addition to teaching the information on the medical equipment, we will be teaching them design and how to go through the process, so that when they spend that second month in the hospital working with the equipment technicians and the clinicians, they will be going into it with kind of the purpose of, okay, what I'm going to find the one problem that I feel like I could have a solution that could have a great impact, even if it's just at this local hospital, but presumably it would apply to many other hospitals as well. And so at the end of their 2-month program, they have to write up a design proposal that will feed into our design program. So initially with the senior design program, but we also have a college-wide design program that is interdisciplinary or multidisciplinary. So we have a few of these design teams right now. The other thing is it's not just seniors, it's freshmen through seniors. And so you get a longer term activity, so that you're not working for a year and then you just leave. We want students to take on responsibility, work with it over a longer period of time, and maybe continue after they're done with their degree. And so through these 2 different design activities, we hope that the students will have this in-country experience and then return and work on the design problems. They will now be a resource to their team because they have the knowledge of how this design, if it's really feasible, if it's going to make a difference, and be able to give that quick response of, no, the power is not going to stay on all the time, or whatever it is, because they just need that basic information about the context. And again, we're really planning on partnering with our collaborators in Rwanda. So we have the equipment technicians and the clinicians. We're partnering with a colleague from Engineering World Health that lives in Rwanda, and he has his own company where he's distributing medical equipment around the country. And so we want to be able to find a sustainable solution with them, so that they are contributing to the design to really make it a long-term relationship and a sustainable solution. And then finally, one other activity that we're doing within our educational program with the kits, and even beyond that, through the EWH kits, but also so I teach the instrumentation, the bioinstrumentation lab, and so we just try to integrate global health even in small little sound bites. We do the kit build as one of our labs, and so they learn how to solder, and they just love it. They absolutely love it. So if you have a lab in your department, the students just absolutely love it. And we teach about the second lab, and I said, I'm sorry, it's all going to go downhill from here. But they. So in addition to that activity, whenever we learn something about, if they have a temperature sensor lab, then I do a little kind of case study or example about how, temperature sensors are used in incubators. Incubators are something that's, really important. Here's an example of a design group that came up with an idea for a sustainable solution that can be built in, locally within, out of wood and, a car heater. And so they just are given examples of how to come up with simple solutions, because I think that, they get plenty of the complicated and challenging instrumentation. And so I think it's good to give them that simple solution and how it can have a great impact. And I think by putting it in the context of global health, they get very excited and they feel like they can make a difference in the world. And so, we're finding that it's very inspirational for our students to be involved in these activities, and I think that we can make a difference as well. So our summer institute, just like the other summer institutes, are open to non-A&M students. It's a study abroad where our students get credit for it, but it is open to other students and graduate students and whoever. So if you're interested in that, I can tell you more about it. But I'll stop there. Thank you very much.
All right, thank you, Dr. Maitland. So I think we've heard quite a great number of presentations about, which I think share some common themes, which are, technology is a vehicle for education, for capacity building, that there is a lot of effort going on to try to find the appropriate technologies for the appropriate place. And I actually appreciate Dr. O'Connell's push and pull analogy. I think in global health, we're very much operating in a pull system where there's a lot of effort spent on identifying needs, and so I'm glad that was emphasized. I want to open it up to the floor and see if there are any questions for our panelists.
Sorry, Matthew, I can't see anything.
Oh, okay. Do you know how to turn off the thing? We see you. We're having, with a technology conference, you're supposed to have glitches, right? God. We can't stop sharing the screen. Yes, Margaret.
Yeah, I still can't see. I have a blank screen here.
I don't know if we're going to be able to fix it, Mario. We're not able to. I can't seem to get it to work. But we can see you great. So you just keep smiling.
Well, keep on trying. You might be able to do it. Because it'd be nice to see who I'm talking to.
Absolutely.
So I want to thank the presenters. Will all of you express that you are using students?
I don't know if you wanted to.
You like it to come?
Try.
Thank you, our presenters. Most of you expressed this need that you are using students to come up with these designs and what. My experience is that sometimes the students sort of go away. You said they will go away after that, and you hope that they will be continue and maybe find an industry for them to produce whatever they have designed. But who will coordinate them when they have left your institution? I mean, they're out on their own, they are independent, and so we have to think about sustainability in that way. And the spare parts, this is Ben. Ben, you talked about. So these things we have seen either Europe or America, they give these donations, but these are the things they have written off, and then they send them to Africa. Sometimes they actually come when they are already not functioning. So we keep them there. We don't know how to dispose them off, and we find that some of them may be functioning, but they will function for a year, and they break down, and they are no longer making spare parts because they have written it off. So I don't know whether sometimes we feel we are dumping ground because we are poor, so we have to think about that. And so that Ben, your program, I don't know that it is really technology or you are transferring this donated equipment. I'm glad that you are trying to convince those people that they should buy equipment.
Yeah, so our program is mostly about dealing with the issues of donation you spoke of. When EWH first started, we actually did some donations, but when the research started coming out and we started getting more numbers back from the Summer Institute, because the students actually perform inventories and do some other work so we can track what's been happening to the equipment, we found out that donations are actually a bad thing, and we stopped doing donations. Like I said, some of our chapters do try to work with MedShare, is one of the bigger donation groups in the U.S., and they work with MedShare to try and vet the equipment and get that percentage up of success for donated equipment. But EWH, our goal is to eliminate donations. That's what we'd like to see. And in terms of what you're talking about with student projects, I think that's a very big challenge for us. And I think Marian mentioned continuity is something that's really critical, and I think it's building and it's growing right now. Especially you're seeing more and more venture capital groups coming out for social ventures. You're seeing more and more students wanting to take these projects to the next level. So we have our design competition where we give a little bit of funding, and we've had several groups take that funding and start small companies. So that's really, the starting of this movement, I think.
So, but like she was saying that Rwanda is going to start like a partnership and putting in money, but we have seen this maybe Rwanda is a bit different, but in most of our countries, when the governments sit and they say we are going to partner with maybe an NGO or UNICEF or whatever, and then they say we are bringing 50% and you are bringing 40 whatever percent, it ends up like the other partner brings in the money and the government doesn't put in the money. So it's like this percentage is doing the 100%, so everything is sort of half done. So I don't know, there are so many challenges in most of these African, and we have to look at the whole scenario. There's corruption, there's, no goodwill. There's a lot of things when you are really working with these African governments and the situation. So we really have to think hard on how to bring in these technologies. You find that there's an individual is a champion like myself. I push a lot of things, but sometimes you don't have support from government. So it is like I'm working with the American or whoever, and you sort of push and drag it into the people to accept it. So
yeah, I think it's very challenging, and so we are trying in multiple ways to try to get it to engage. And so by extending it from a single-year student design project to a 4-year design project, where we get students to have more continuity over a longer period of time, and then also to engage people in Rwanda. We'll actually have some Rwandan students participate in the training period for that first month, so that they could also be somebody locally that can participate in that team environment. And then and really trying to evaluate the manufacturing there, and I think it's just spending as much time as possible in the country, finding the people, working with them over a long period of time, coming back every year. Unfortunately, we can't stay there the whole year, but 2 months each year, and trying to target specific individuals. Working with the Ministry of Health, I think, is so important, and I think in Rwanda they're currently they're very supportive, but I think that it all depends on the government and who is in the government. I think corruption is a big issue, but at least right now it seems like Rwanda is a special place where they have a real drive to be successful, and I think that there are other countries where it just, you can't get any traction because it's just, so difficult, and so it's a real challenge, I think.
And I just want to add, I taught at Engineering World Health's BMET program in Rwanda last year. It was a great experience, and I met with some of the faculty in the College of Engineering at KIST there, and there's no biomedical engineering program in Rwanda. I feel like creating a win-win situation here means building industry, a medical device industry, building capacity, and a big part of that is to have a biomedical engineering degree program to actually be educating people. But involving stakeholders, whether it's the medical device industry here that wants to locate somewhere, in a lower resource setting, or building the industry from the ground up there is really important. I fully believe that if we don't have commercializable products and people can't make money either through the supply chain or transportation, et cetera, that we won't be successful. So that's the sweet spot that we're trying to find.
Can I make a comment? Hello?
Yeah.
Can I make a comment?
Yes, sir.
Regarding the question that was made of this dumping of equipment and equipment being in some of the countries in Africa or South America, where equipment is sent and then it just works for a while, or no one has the parts. One of the things that some of us within IFMB are really concerned with and trying to link with the WHO is try and get some of the equipment, some of the devices to be approved. They should be compatible. Like all the EEGs, all the EKGs, they should have some compatibility. So you make sure if one system doesn't work, you can get some compatibility with the other from a different brand. So getting something like that has to come from the top. It would take years, I agree, to get this implemented. But once you get some guidelines, there's some compatibility, then the possibility of equipment being there and not being used at all because there's no parts for it, there should be easier somehow to interchange some parts of the equipment from one brand to the other, and make things have a longer life and be easier to use. And the problem is that some of the companies have this equipment that's completely closed, and want to send, if you try to repair it, they said, no, this is actually designed for the rich countries, where you take the whole electronics and put a new piece, and no one repairs it. And sometimes they do that on purpose. So somehow, if there's some directive from the World Health Organization to try and get some of the simpler equipments, to get some of the compatibility, I think probably help. That's just an idea.
And I just wanted to echo the importance of having a continuous presence in the country. I think we've been really fortunate with our program that the Botswana-UPenn partnership has been there for 10 years. I'm there year-round, et cetera. So we build relationships, and relationships are very, very important to the sustainability and the buy-in of local partners. Another thing is convincing local partners to invest in these projects. Like we're saying, that's a big issue, is getting them to actually do the 50% of their side. But once we had Orange, our telecoms partner, and the ministry and other people actually investing things, putting things in their budgets towards these projects, then they were more interested in the growth and success of it, as opposed to if it's just a donor thing and people are there for a few weeks or a couple of months and then they're out. They're less invested and less interested in its success.
Is anyone looking into training the people that live in the villages in how to repair the equipment or operate the equipment by bringing them to the U.S. or to Europe and spend some resources on developing their knowledge?
So a lot of our partners, in fact, a lot of our teachers in Rwanda and Honduras and our other BMET programs actually are exactly that. They work for GE, they've in the past have worked for GE or Siemens, and they've gone through their training, and that's where a lot of times they've gotten their background in BMET training. But that's not really an option for the majority of the people in these countries. So really, sorry, go ahead.
Why not?
I mean, well, again, it's been sponsored. They're being paid by GE, not the GE Foundation, but the GE corporate, to learn how to repair this equipment for GE. They're not very invested in finding enough technicians for every single hospital in all of these countries to repair their equipment. Their model is more based on having service providers, maybe one or two per region or per country, and having them go out and repair the equipment. So what we do is we're trying to give the baseline knowledge to every single hospital, so that hopefully they don't have to call up whatever the GE rep might be if they're in country. They may be in the country next door and have to, flip the bill for those expenses to have them come in and make the repair. In terms of rural villages, there's not really a lot of equipment in rural villages. A lot of times in these rural areas, they have very basic healthcare facilities, maybe 5 or 6 beds. They might do C-sections there at most. If you're looking for really the equipment-intensive facilities, are going to be in the big cities.
That's the real issue, that you all come, you are in the big cities, but our problems are in the rural areas. How are you going to address that? And that's why we are looking for the low-tech, easy to maintain, so we don't want the GE incubators which are occupying half the room, one incubator. So we want the less sophisticated equipment, but it can do the job.
Yeah.
And we can take it down there, and even a simple midwife can operate it.
I think this presents a really interesting challenge to engineers, actually, is going to these rural areas and seeing what existing expertise exists in these areas to support things. Like, you go to rural areas, there are guys who know how to take apart cell phones and put them back together. So then try to create, and there are guys who know how to take apart clocks and all these other things. I think it's a challenge to engineers to create useful tools out of these low-tech items in these areas.
But what about finding that person that can take apart anything and fix anything, and bringing him to the U.S. and giving him a degree, or making him have a degree in engineering?
He'll
going back to his village.
Well, brain drain is the real big issue with that, unfortunately. I guess there's ways that you can contract things so that they have to go back to their country and work because of the donation that was made for them to get their education. But most of the time, they're more interested in going to Europe or the U.S. and finding a job that's going to pay, the levels it would for the education they've received.
Can I comment on that?
Even if they didn't bring somebody for a degree, because it is too expensive, but if they came there and they trained people, many of them down there, those smart guys, I mean, there's always a smart person somewhere, and they train them to really maintain and look at that equipment, I think that would be good, but they never do that. They stop in the cities.
And I want to bring up that, appropriateness goes in both ways, and that's one of the big challenges when we think about educational, partnerships. There's a lot of people wanting to send students, trainees from the U.S. to other countries to go and implement these long-term sort of things. And the difficulty with doing it this side is that when someone trains here, I can speak really only to medicine, the decisions that we make in medicine, the ways that we operate or the ways that we make medical decisions are very technology dependent. So we train someone on how to make medical decisions with lots of resources, and then we expect for them to go back. And I worked alongside many docs in Botswana who had trained outside and really had a hard time reintegrating back into that system. And in fact, it was one of the top cited reasons that they don't want to come back. So I've learned how to take care of people with all these resources, with all this technology. Now I got to go back and not have it. So that's yet another challenge to, how do you train someone who can take apart like a bush mechanic. Anybody who's ever, crashed or had a blowout or a problem in the middle of the Kalahari Desert or anything like that knows that these guys can fix anything. But what happens when you bring them somewhere where there's all kinds of equipment and then they've got to go back and try to implement that? But I think those are all wonderful, wonderful points. There was a question in the back.
Yeah, just quickly to follow up you ever thought about going to the universities and having the students there learn with your students? So if you take your kids there and they're learning, can you just include them, and that way you're teaching them?
We're doing that.
Yeah, that's one of our partnership goals too, is to partner our students with students at a university, and you know, identifying the right partners is going to be really critical. And one of the first places we're looking at is Honduras, because we have a good university there, and we think that there's enough infrastructure there that should this program happen, there's a chance for success. And it's very interesting to look at, for instance, the biomedical engineering program that exists there versus the biomedical engineering program that exists at our institution. So the focus, many of their students are taught to, there's a heavy focus on repair in the curriculum and those skills. Whereas the focus in many U.S. institutions, and most, I'd say, in engineering, is in design and innovation. And there's a certain amount of empowerment that has to be given to the students to let them know you can innovate. You know, they have to feel that there's a reason even to innovate. So finding a way to create a situation where the skills of both sets of students can be expanded by working together to create, you know, really sustainable innovation and commercializable innovation, something that can actually be sold. It's a real challenge, or I'd say it's an opportunity. It's a good opportunity.
Dr. O'Donnell, I think you had a question.
Yeah, sort of a meta question, but I want to hear it from you all in the trenches. That when I hear this now, it reminds me of where we were about a decade ago in infrastructure areas, which eventually has become the International Group Engineers Without Borders. Okay, so the Engineers Without Borders and little local chapters, and everybody's going into their place. And let me tell you, you talk about your machine reminding me when you had the imaging systems that were museums. If you go to the Alto Planto in Bolivia, you will find a similar thing for infrastructure. Water systems that don't work, that were based on old, certain levels of technology, all that. What's happened though is they've coalesced now into this common organization. Still got a long way to go, but you really have coalesced into this common organization called Engineers Without Borders. So what do you think about for global health? Do you think that you need a parallel tech? Do you think you need a single unifying? I know there's a bunch of them that are good, but do you think a single unifying organization with local chapters is a way to go? Or do you think it's still just let everybody compete, go out and do their stuff, and the best things will propagate at the top?
Let me actually, I'm sorry, I can't see anybody. Let me just actually ask Mario, maybe you might want to comment on this first. This is a question from Dr. O'Donnell regarding, the success of organizations like Engineers Without Borders has been sort of international mandate with local chapters that are implementing locally designed projects. And the question is, for global health, is the same sort of mechanism a possibility? And maybe with your experience with IFMBE, you might be able to speak to that first, and then we'll hear from the rest of the panelists.
Yeah, so what happens is that the actual health needs and situation throughout the world is completely different. So just having one organization to think globally, sometimes you lose a lot of the local points, and you get just covering all the general ideas. And if you look at Europe, and I live in Portugal now, which is a European country, but having come from Mozambique, having been there regularly, the actual needs, the health problems are completely different. The technology that we use here, the technology they use there is completely different. So instead of having just one global approach with just one organization deciding on everything, I think it's much better to look at specific situations within regions. I'm not saying country by country, but our idea within the International Federation of Biomedical Engineering is look locally at specific groups, because even the needs in Africa are quite different from the needs in Southeast Asia, where the actual diseases and the problems are somewhat different. The technology they have is also different. So it is very important to get these local groups and look at the local strategies rather than just have a totally global approach. And obviously the different groups have to be coordinating with a bigger group, which see what is common between the different sites and put it all together.
Yeah, let me just comment back on that. I mean, that's what the Engineers Without Borders, so a UW chapter, University of Washington chapter, which goes to Bolivia, doesn't do anything like University of Texas chapter going to somewhere in Botswana. I mean, they're totally independent, they're totally related to the local issues, but what the central organization does is links folks to corporate partners, links them to funding sources, links them to social, government organizations, NGOs, that type of thing. So that's what I was sort of getting to. The local character of a project, of course, is going to drive that.
I see what you mean, and we're on the same line. That just some of the policies have been put together because they can't really talk to different directions, but have locally the specific situation for each particular country or region as such. Yeah.
I think there are multiple models that can work, and I'm for free enterprise, so and try as many different things as we can. So going at it from different angles, I think, is a strength, and the ones that ultimately succeed, will stick around. So that's my personal preference.
Oh, yeah, let's go with that one. Yeah, I'll have to agree with Dr. McCord on that one. I'll also add that we're, like you said, we're sort of where we were 10 years ago, maybe with Engineers Without Borders, in terms of the projects are very technology intensive or development intensive. I feel like with Engineers Without Borders, it's more implementation is, I guess, where a lot of the phase that they're at right now. So I think it takes a lot of, really specialized knowledge in certain areas to be able to develop, some of the technologies that we're thinking of. Yeah, so I think that's one reason why, I think we're going to go a little bit of a different way from this more civil engineering oriented Engineers Without Borders. I had one other thought, but it's escaped me. So, Jamie.
Any other questions? Someone in the back?
Yeah, just a general comment hearing all of this is, I think we should not lose sight of the fact that part of what we're trying to do is also create the partnerships and the human capital in country. So what if an undergraduate senior design project did not translate into saving 1 million lives? It would be very nice if it did. But in the process, you've actually seminally changed the lives of some engineers here in the US to think differently. And hopefully, if you've incorporated local partners there, you've contributed towards changing the ecosystem there a little bit. But one thing I would like to hear from you, the panel, is this seems like a very one-way traffic so far from this conversation. That we are donating equipment, we are creating partnerships, we are, sending down knowledge. But from my experience, it's been that there's really so much learning to be had, not just in identifying needs, but learning to be had from how we do innovation, how we think about culturally appropriate innovation, and sometimes really the whole notion of frugal thinking, constrained design, really comes. Our students have so many times repeated this, where they're chatting with their local counterparts in their institutions of excellence. They just would not have been able to think elegantly about design had it not been for someone who knows a little bit about engineering, a little bit of design, but has been fully culturally immersed for their entire life. So I would like to hear from the panel if we're only talking about a one-way knowledge transfer, are we truly going there with an open mind where our teams are also truly learning about not just needs, but about the process itself?
Absolutely, and I completely agree. So we look forward to our students working with the equipment technicians in Rwanda, and that they'll gain a lot of knowledge in just their approach to problem solving, that I think our students will learn so much about that. The other thing is that I think that the equipment technicians are given a lot of skills, and they're given knowledge about the equipment that they're repairing. I think that our students will actually educate them in some way of how they approach problem solving. So just even if it were an American and a European getting together and working together, they've been trained in different systems. They will learn from each other. I think that both the technicians and the American students will gain significantly just from their experience working together. And so, and in that sense, it's an educational opportunity for anybody working in that group. And so, even if it doesn't result in something tangible, I think the education that comes out of it is very valuable. And that's in both sides. It's not just for our students here.
Yep, I absolutely agree, and I'm always using the term co-developed solutions, and I really don't want to be a part of any kind of proposed solution that doesn't involve bottom of the pyramid stakeholders, in these global health contexts. So context-sensitive solutions that are really the effort of a team, including the people, not just technicians or students or faculty, but end users in communities. And I think that's incredibly important. And it is a two-way street. There is a lot, like frugal engineering, Gandhian engineering, there's a lot of different types of thinking that American students and faculty can learn by going and immersing themselves into these settings and working with a team there. So absolutely.
Sorry. I appreciate everybody putting up with some of the technological limitations. We are in a resource-limited setting here in ballroom 3 through 5. I want to especially thank our panel for sharing some insights. I think I certainly have come away with a lot of stuff to think about, certainly from the questions that have been raised about not just doing the best for the world's most resource limited, but also doing it with equity in mind and with an idea that there's much to learn on both sides, and that the processes that we're using to implement these things and to design these things really must be much more two-way than they have been in the past, and that the old model of development, which is bring aid in and try to do something locally, will inevitably we'll find ourselves where we are now, where we're not quite sure what we're doing in development. So I really want to thank our panel for sharing insights, and please give yourselves and the panel a round of applause. I don't want to keep us any longer because I think there are there's a space medicine talk there's a space technology talk that's going to be happening over lunchtime. So let's all break for lunch. Mario, thank you so much for putting up with the Google Plus. Thanks to everybody for coming.
Thank you.
It's okay.